Welcome to The Long Strange Trip. I'm Josh, the host of the show. We're going to dig into 6 areas together, finding real work-life integration instead of that brutal 95-5 split too many business owners live with. We're going to approach retirement as an actual reinvention rather than just stopping work. And we're facing death honestly and avoiding PTSD around it. We're also building resilience when life throws us curveballs. We're sharing wisdom across generations. And finally, we're understanding the patterns that show up in all our transitions. I'm not coming at this as an expert. I'm a fellow traveler, figuring this stuff out in real time, especially now as I navigate my own dual cancer diagnosis at 73. Welcome to The Long Strange Trip. I'm glad you're here. Hey, how are you today? This is Josh Patrick, and you're at the Long Strange Trip podcast. Thanks a lot for joining us today. Today, we're going to have a really interesting conversation. And our conversation fits in generally with my broad scope of how do we die without having PTSD, or how do we face death without PTSD is actually a better thing. And today, I am really, really happy that we have 2 folks with us to talk about this topic. And they are from Patient Choices Vermont. We have Amy Bruce, who is the executive director, and Betsy Walkerman, who is a board member of Patient Choices. Betsy and I have known each other for years, and her father was very instrumental with doing what's called Act 39, which is the legislative piece that talks about this. But since I am not an expert on this, and Amy and Betsy are, let's bring them on and start the conversation. Hey, how are you folks today?
Great. Well, thanks for having us.
Thank you so much for coming on. And this is really interesting. So I don't know who wants to start. Do we want to do a history of Act 39? Or do you want to talk about why it might be important for folks? But we do want to talk about both. And I don't really care what order we do it in. Who wants to start?
Well, great. I think I can do a little history. So Patient Choices Vermont started in 2002. That's when my dad, Dick Walters, and my mother, Jenny Walters, got started with the idea of getting a medical aid in dying law passed in Vermont. At that time, there were only 2 other states that had a medical aid in dying law. That was Oregon and the state of Washington. And so just we'll get into more detail about what medical aid in dying is and isn't, but just the brief summary is that medical aid in dying provides a legal process for people who are facing a terminal illness with a prognosis of 6 months or less to live to make a decision to request terminal medications so that they can control the timing of their death. And it's only available to people who are cognitively able to make their own decisions.
And what do we mean by cognitively able to make your own decision?
It basically means that the person is already making other decisions about their health care. So it's the same kind of standard that that a medical professional would use when they're speaking to a patient about any of their other decisions, such as, if you have cancer, whether I'm going to pursue surgery or whether I'm going to pursue chemotherapy. So the same kind of judgment call there. So if I'll just sort of finish the history really quickly. So the process to get our Act 39 in Vermont passed took 11 years. There was a great deal of discussion all across the state and in the legislature. And in 2013, the legislation passed. We were the first state in the country to pass it by legislative action rather than referendum, which was a very big deal because the next few states that adopted medical aid in dying were California, which was has a lot of population, and Colorado and New Mexico. And now we have 13 states, soon to be 14 states, we think, that allow medical aid in dying. So about a third of Americans have access to medical aid in dying. So here in Vermont, once the legislation passed, we turned our attention as a nonprofit organization to education, helping both patients and physicians and families and hospice organizations understand how the law isn't what's intended to work, and coaching people through their process, considering their options.
So you folks do the coaching for this.
We do some of it. I mean, at this point, there are quite a few people in the state who have a lot of experience with medical aid in dying, especially doctors and hospice professionals.
So, Amy, why would somebody want to use medical aid in dying?
Mhm. So first off, I'll say something that will be, I guess, really obvious, but receiving a serious diagnosis of an illness that could be life-threatening is probably one of the most terrifying moments that any of us may experience. Um, and I think when that happens, people's brains tend to jump ahead to what could the end look like? Now that someone is telling me that my end may be in sight or potentially foreseeable, things go from theoretical to real really quickly. And people deserve to be able to understand what that path may look like. Of course, none of us know, not the oncologist, not the pulmonologist, not the priest, not yourself. None of us know exactly what that path will look like, what it may require of us and what it won't. But we deserve to know what all of our options are and to feel, I think, especially I think in this Western culture, to have some agency, right? Some control in a moment where we feel like a lot of control has been taken from us, to understand these are my options, and this is what I'm legally entitled to and deserve to be able to talk about openly with my doctor, with my family, to really understand, how to make the best decisions about life from that moment of getting that diagnosis until you draw your last breath.
Yeah. This is something that's really interesting. I've had 3 cancer diagnoses. One was 18 years ago where I went through a really serious thing. And it was very interesting. When I went through my cancer experience 18 years ago, I never thought about dying. It wasn't something that even came in my eye. And it may be because I was 55 years old. Now I'm 73 years old and I've been re-diagnosed with my non-Hodgkin's lymphoma as well as prostate cancer. So now it's real. And the reality is I'm probably going to die from one of those 2 cancers. When, who knows, but that's the problem. I would say that's the probability. Now, the thing that I have found, which is really sort of, I'm finding it disturbing, is that none of the medical team I've been working with has talked about end of life. And this includes, I have an oncologist up here. I have a radiation oncologist up here. I have a team I'm working with at Dana-Farber. None of them have mentioned there's options in how do you want to die. And I know that's not what they're trained for. And I know that's not what they get paid for. But how do we change that? Because that to me seems to be a hugely big deal. And these are all really good doctors. And I know at least my oncologist is fine with medical aid in dying. He just, when I brought the subject up of my demise, he really kind of almost curled up into a ball. Not really, but metaphorically. And he's a great doctor. And I know that it's just why, what can we do to change that? Because I think that's a big deal.
Well, I think I'll go first. I mean, I think it takes work on so many levels of our society and our culture, certainly medical education, ensuring that people, regardless of the specialty that they're going into, have some grounding in how to have end of life care conversations, goals of care conversations with people. People have to understand that, your physician's office and those appointments should be the safest space for you to have those conversations. But if you're quickly getting the message from that person that I'm not comfortable talking about this, you're certainly not going to pursue it. So starting with medical education and providing them the training, it's we want them to be able to do this, but it is a skill. Having goals of care conversations and helping people explore this topic is a skill to be learned, like any other medical skill. And then culturally, the work that you're doing in this podcast, and that the growth of the end of life doula movement is doing so much. Death cafes, sprouting up all over rural and urban America. So I'm doing so much to help people understand we are all going there, and it's only going to be harder if we continue to look away, and we may miss so many opportunities to pursue life and live life in a much more full way. So it's work, very technical work on training people on if medical aid in dying is legal in your state. As a healthcare worker, this is your responsibility to understand it and be able to talk to people, but also having those cultural conversations, supporting art and film around death and dying. It's also important. So it takes everybody.
So some of the stuff I've read says that even folks who qualify for medical aid in dying and go through the whole process and get all the pills they need and all that, is that often they end up not using it and going through with, I'll call, natural death. Have you guys done any research into why?
PCV hasn't done specific research into this. I think that, again, like going back to where I started, that when we first, are experiencing a serious illness, and take cancer, for example, we may make assumptions or have fears that this is going to inevitably lead to a high degree of pain or an unbearable level of existential suffering that we would choose to not go through. And so to have a prescription for a medication that you can take independently, if that moment arises for you, what we do hear from people is that, and I'll let Betsy speak to this because I think she's talked with people personally about this, it allows people to relax and really be able to live the life that's still in front of them.
Yeah, I'd like to comment on that. Yeah, I really, having been involved in this work for more than 20 years, once the legislation passed and people started to have, at first a few and then more people who use medical aid in dying, I started to have more conversations with people, and we have actually quite a few videos on our website that capture those conversations and some of these questions with both families and people who are planning to use medical aid in dying. It's a very, very personal decision, and and you can always change your mind. So you can start your way through a process. We actually encourage people who want to consider it to start the process, and then they can decide whether to finish the process or use the medication or not. But the process does take some time. So if you want to have the option, you can't decide on the spot on a Friday morning, get me that medication today. It's not going to work that way. So people do have to, this is really the value of having these kinds of conversations, because people really do have to plan ahead in order to have the option at all. But once they do qualify, and they either have the medication in hand or they know that the arrangements have been made to obtain it through their doctor and the pharmacist quickly, then it really provides a beautiful window for people with a measure of control. I went through this with my father, who died from lung cancer in 2015. And it really opened a beautiful time for connection for our family in the week, after he had made the decision, but before he used the medication. And, his words were that he had some of the deepest, most important conversations of his life in that last week. And it opened a really special time. He said, because people knew he was leaving, they spoke to him in ways that it just never happened. And he was a talker, so um, he loved to have deep conversations with people, and that really came out. So that really made me shift my perspective on medical aid in dying to the perspective that it's a life-giving treatment, that it's about the life that you're living in your last week or 2 weeks or 2 months, 6 months, and less about your death.
So it sounds like the process is relatively complicated to get approved. What is the process?
Yeah, Amy, why don't you run
Sure.
through?
Right. So as Betsy said, it is good to start these conversations early, ideally with your own doctors, regardless of whether or not you're in Vermont or where. To talk with those doctors about what you're thinking, that you'd like to talk with them about what they see as a potential trajectory of your disease and what options might be for you. And then after that, ask them, is this something that not just do you support, can you support me at the end? Because of course, every doctor we hope would say, of course, I will be with you to the end of your life. But do you prescribe medical aid in dying? Or can you refer me to a doctor who can prescribe medical aid in dying medication? Because identifying that prescribing physician is the first really important step. And then once you do that and you have an initial appointment, that's considered, if you request the medication in that appointment, you make that first oral request for the medication. That doctor then assesses and determines if you're eligible. And if things are going to move forward, you need to have a second appointment with that same doctor no sooner than 15 days later, right? There's a built-in waiting period of 15 days. That's designed as a safeguard, right? To give everyone time to really reflect on this very most serious decision. And then you would meet again with that doctor 15 days later, make a second or longer, right? A second oral request. You also need to submit a written request for the medication that's signed by 2 witnesses and have an additional appointment with another doctor that's called a consulting physician who's going to affirm, yes, you are eligible, you meet all the requirements. Once all those conditions are met, then the doctor can prescribe the medication and send the prescription to a participating pharmacy.
So I'm assuming that unless you're in that 6-month window, you can't even start the conversation. Am I correct with that?
You wouldn't be able to make an official first documented oral request for the medication. You would not be eligible unless you have that 6-month prognosis, but it certainly doesn't mean that you can't talk about it, right? That you always should be talking about the goals you have for your care and the rest of your life.
Yeah, I mean, everything I've been reading, especially books by doctors about end of life, saying you really need to rethink how you want to go through the end of your life, because the medical industrial complex is not the way to go. That's not going to lead to a good death. That's going to lead to ICU and dying by yourself, which I don't think any of us really want. Do you folks get into that sort of education about what the difference between a good death and a bad death is?
Well, I really, well, we don't frame it that way because I think it's a highly personal experience. There are people who may choose to pursue treatment to the extent that they understand that their death may occur in an ICU, and that
Yes.
may be appropriate for them. That may be desirous for them because they are interested in pursuing options, medical options, until the very last, possible moment. That may be for them a good death, right? So, but what we do is we do talk to people about, encourage people to think about this. Let's all be brave together and have a conversation. We do this in person. We do this online with people. Let's not turn away from this, but think about if you reach a point where you aren't capable of speaking for yourself, who would you like to speak for you, right? And to help people with that advanced care planning, we collaborate with the Vermont Ethics Network, who really does the bulk of this work and supporting those conversations in Vermont. We provide people support on how to talk to your doctor, right, about medical aid in dying, how to bring this up. And we provide people these little wallet cards, which people really seem to love, that kind of are just a guide to end of life conversations and how to talk with your doctor and your family, the questions that you should be asking.
Well, I'd like to just mention some of the resources available on the website. So our website, patientchoices.org. You mentioned, so for people who are patients or families, there is a guide to medical aid in dying, which gives you all the basics in a very clear, simple presentation. There is also a section specifically on how to talk to your doctor, what kinds of questions to ask, and how to evaluate those responses. There's also a full clinician's guide for medical professionals. And you mentioned before, Josh, about trying to have a conversation with one of your doctors about end of life and medical aid in dying. There's actually one of the first sections in that clinician's guide is summarizes some key questions and conversation topics that medical professionals, especially doctors, can use to understand the patient's values around end of life, to understand what's important to them. Is it most important that I'm able to listen to music till the very end? Is it most important that I'm able to have a conversation with my family? Is it most important that I'm able to get up and walk into the garden? What are the values that are really going to drive what kind of end of life support you might want?
So what kind of professionals would be able to help with this besides doctors? And my next question is, is it better to have a conversation with your general practitioner or with the specialist you're working with about your particular disease?
Well, I'll answer the last question. The second question first. I think it's important to talk to both, right?
Okay.
Or if you're in active treatment for an illness, then that person certainly needs to understand the goals you have for the rest of your life so they can help you make treatment decisions, right? If a chemotherapy is going to be so debilitating that you cannot meet those goals, like Betsy just mentioned, if that's going to be taken away from you either temporarily or permanently, is that okay with you, right? So but a general practitioner, they may have, much more experience with you. That may be somebody that has known you for decades. And so they might be more comfortable, to talk to about that. You may be able to have perhaps more time with them. And it may be, so it's really dependent, I think, on your relationships. And frankly, you're going to maybe dip your toe in that water, and who are you getting a strong response from, in one way or another. I think it's really going to be kind of situational, but I would encourage people to talk to everyone that they're getting care from. And then regard to, who besides doctors, certainly if someone is at the point where they're no longer seeking curative treatment and they're enrolling in hospice care, there isn't anyone on that hospice team that you can't talk to about it. The hospice nurse, the hospice social worker, the spiritual advisor. Often people have very close relationships with the home health aides that work for hospice that do that very personal care. And sometimes those home health aides come back and share with their care team, do you know what, Mrs. Jones told me today? I think this is really important, right? So everyone on a care team, and if you're not on hospice, if you're getting home health, and talking with the home health nurse, I think anyone that you're interfacing with, that you want them to know you, to know what you're thinking about, to seek their input is important. And again, I firmly believe, and we work at Patient Choices Vermont to ensure that everyone in Vermont that works in healthcare understands this law exists and this is a legal right and this is how people qualify, and everyone deserves to have the knowledge about it. And you as a healthcare worker, it's your responsibility to have an educated conversation and supportive conversation, regardless of your own personal beliefs, because again, not people are not compelled to participate, right? Physicians are not compelled to offer this service and provide this medication. And the same is true, throughout the healthcare system. So, but that doesn't mean that it's not a responsibility to learn about it and be able to talk about it.
So I have two more questions we're going to ask you, then we're running out of time. So, but my first one is, where's hospice and palliative care health professionals fit into your world?
Well, we work very closely with them. One of our very important medical advisors and board members is a palliative care and hospice physician, actually two of them on our board and another on our advisory board. We really see medical aid in dying as part of comprehensive end-of-life care. So it's not a binary choice. It's not you choose hospice or you just grit your teeth until you take the medication, right? It's people deserve to have full support that hospice can provide. Palliative care, ideally from the very beginning of a serious illness all the way through. Hospice is one form of palliative care, but palliative care can be offered earlier than hospice because it doesn't have the requirements that hospice has.
Right.
So we're partners with hospice and palliative care. We don't, we support that. We support the growth, and we encourage everyone who reaches out to us with questions about medical aid in dying. One of the first things that our volunteers say is, we strongly recommend you enroll in hospice when you become eligible.
Cool. Thank you.
Yeah.
And my last question is my weird question. I have personally experienced, and I've read a lot about, there's what I call this liminal space between life and death. And in that liminal space, I've seen people have conversations with people who are not in the room. They might use their hands and flop around a bit. Sometimes they pop up and are completely lucid, even though they're really in the end stages of dying. And if I use medical aid in dying, do I lose that liminal space?
So, such a profound question. I very much appreciate it. People do wonder, and we get a lot of questions about what does this really look like?
Yes.
And how does it feel, right? And so I think your question gets to that. And what we can say is that when people take the medication, they fall into a deep sleep and then unconsciousness within a matter of minutes, 5 minutes, 10 minutes. It happens very quickly. What happens after that moment is not known to anyone except the person that is in that state, right? I will also say, though, that, in hospice care, sometimes people will, push away medication. They'll decline pain medication because they want to maintain their lucidity. And perhaps that's one of the things they're thinking about, is I want to be present and conscious of this transition that I'm about to make. But if you're so crippled with pain, that's also going to, I would think, this is kind of my personal opinion, but I would think that's going to make it hard to be attentive to that higher level of consciousness.
By the way, I am a huge believer. There is absolutely no reason for anybody to die in extreme pain.
Yeah.
We have tools for that, and we should be using them. That's an editorial comment.
But I'd love to hear, Betsy, do you have thoughts on?
Yeah, actually, I've seen both. Just with my parents. My dad, of course, used medical aid in dying, and his process was very much as Amy described. Fell into a deep sleep very quickly. I would say also that he had the combination of both medical care, palliative care, and hospice care. And the combination was really helpful. Everybody brought a different, slightly different perspective to his situation. But he was very clear that he did not want to face the very end stage of that disease. My mother, on the other hand, somehow she knew she was dying in the next 2 weeks. She went through the process. On a Wednesday, she wanted us to connect her with with various old friends, which we did. Had a series of Zoom calls because she she somehow knew that this was the end. By Thursday, she was calling my sister saying, I'm seeing things in the room that I know aren't there. Very much like, and what she wanted this to be documented because she was fascinated. She was a scientist. And so she was fascinated by what was going on in her brain. And she wanted people to know what was going on in her brain. And by Friday, she died in her sleep.
That's a lovely story. And I'm glad it's true.
Yeah, it was very interesting. I do want to say that we provide support for people at various levels, both community meetings, educational sessions. We have an online series called Exit Matters. There's a calendar on the website for people to sign up, no matter where they are, in state or out of state. And we have a team of fabulous volunteers who staff our helpline. So people, most of our helpline inquiries come in through the website, which is what we encourage, so that people can be thoughtful about their questions. And we provide whatever support we can within that framework. Really appreciate the collaborations that we have with the many organizations around the state of Vermont, and with our team of volunteers.
So unfortunately, we're out of time. So how do people find you guys? And what would be the first step they should take?
Right. So as Betsy mentioned, our website is a treasure trove of information. So patientchoices.org. Go there. It is the most comprehensive website and one of the few websites about medically and dying in Vermont. So clinicians, doctors see our website and use our website as the source to find all of the information, from the text to the actual law to videos from family members, and everything in between. That's all there for people. There's a specific page on people who live outside of the state of Vermont that really walks people through what the process will look like for them, because there are, logistical challenges. There's other things to think about. We have a newsletter that we put out. We post that there. We put recordings of all of our events. So encourage people to go there. And I will say, we provide all of this for free, largely volunteer driven. There's myself and one part-time staff person, and that's it. So there's not a big group of people behind the curtain. We have a fabulous, very dedicated board, most of whom have been with us since the beginning, and amazing volunteers. So encourage people, if they're interested, definitely look at that. And then it's a lot to digest. Our volunteers can help people break it down. And if you find it useful, if you attend an event or an online webinar and it helps you, if you consider a small donation, a donation of any size, we would be grateful, because we are completely driven by donations. We don't receive any money from the state of Vermont or any other government source.
So let's go for large donations, a heck of small ones.
Oh, I like the way you think about that.
We have been very blessed by people mentioning us in their obituary, like people do, and people have left us bequests, some considerable size. So we're very, very grateful for the support.
Cool. And thank you so much. And I have one thing I would like you to consider, which is, if you enjoyed this podcast and you say, hey, I have stories that are worthwhile too, and I would love to get them out in the world, why don't you send me an email at jpatrick@stage2solution. That's the number 2 and solution is singular, jpatrick@stage2solution.com. And we'll have a conversation about whether being on the Long Strange Trip podcast is right for you. So this is Josh Patrick. We're with Amy Bruce and Betsy Walkerman. You're at the Long Strange Trip podcast, which I just repeated 18 times. Thanks a lot for stopping by. I hope to see you back here really soon. Thanks for spending this time with me today. I really appreciate you being part of this journey. I'd be grateful if you'd leave an honest rating and review. It helps other people find these conversations, lets me know what's landing with you and what isn't. If you love the show, give us 5 stars. And if you hate it, give it 1 star and I'll just cry a little bit. Keep asking the hard questions. Keep being honest about what's difficult. And remember, we're all just trying to figure this out together. I'll talk to you next time on The Long Strange Trip. Thanks for stopping by.